Right, so we'll get tonight's meeting started. Good evening, and welcome everyone to tonight's Journal Club meeting. My name is Ravin Patel, and I'll be serving as the club advisor moderating tonight's Journal Club. I'm a primary care sports medicine doctor, family medicine background. I work in South Jersey at a private practice ortho group and currently live in Philadelphia. I just finished up my primary care sports medicine fellowship at Penn State and State College. So again, to review, the goal of AMSSM's Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 articles that every sports medicine fellow should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunity with actual AMSSM members, the opportunity to discuss, develop skills for reviewing articles, and make PowerPoint presentations. So tonight we're going to have two very great presentations. So the format for this Journal Club, it's going to be two 20-minute sessions, and they'll have time to present. And then right after that, we'll do a brief question and answer segment after the presentation. If you have any questions during the duration of this, you can use the chat function below, and you can put them in, and I'll be moderating the questions that come in, and then we can kind of get them answered. So without further ado, we'll start with our first presenter. So our first presenter will be Dr. Marjorie Morales and her club mentor, Dr. George Pujalte. He's the primary author of the article she's presenting, so that's very exciting. Dr. Marjorie Morales is deeply interested in the intricate balance between injury prevention and recovery, particularly through practices like hot Bikram and Vinyasa yoga. She finds inspiration in the dedication of athletes at the Olympic and Paralympic level, where every moment showcases the power of resilience and peak performance. When she's not immersed in the world of sports medicine, you can often find her mountain biking through rugged trails or kayaking on tranquil waters, all while embracing calming benefits of hot yoga to enhance recovery and well-being. Her presentation is on the article, Differential Diagnosis of Polyarticular Arthritis. I'd like to thank George Pujalte for serving as her club mentor. Dr. Pujalte has been a consultant at the Mayo Clinic since 2015. He has a strong focus on MSK medicine, as well as he works within the departments of family medicine and orthopedic and sports medicine. He's the vice chair of research in family medicine and formerly served as the associate program director for the sports medicine fellowship program at Mayo Clinic's Florida campus. He's the vice chair of research in family medicine and formerly served as the associate program director for the sports medicine fellowship at Mayo Clinic. He also blends his expertise in musculoskeletal conditions with a deep interest in sports psychology, martial arts, and has acted as a physician for the elite Olympic and Paralympic athletes in boxing, mixed martial arts, and even Taekwondo, all while sharing his knowledge at both national and international conferences. Outside his medical career, he finally recalls his days as a lead guitarist in a rock band while he dreams of joining a band in Jacksonville. He now enjoys traveling with his family and engaging in lightsaber duels with the sun as a Jedi Knight. So I want to turn it over to Dr. Morales. So if you want to load up your presentation, we're all excited to hear how it goes.
So the title of this article is Differential Diagnosis of Polyarticular Arthritis. And there are two authors, Dr. Pujalte, as was introduced, and also Dr. Albano Alequin. And I'm a fourth-year Payment-R resident at Montefiore Medical Center, which is in the Bronx, New York. So the big takeaway from this article is the very first table, and that's table number 1. It's titled Clinical Patterns of Polyarticular Arthritis, and we're gonna detail every single aspect of this table so that we can use it in our clinical practice whenever we have patients that come with polyarticular arthritis complaints, especially within the context of our sports medicine clinic. So the patient case that we're starting out with is a 28-year-old male, and he presented at the sports medicine clinic in the Northeast region. His sports interests are as a college football player, specifically in the position of a linebacker. And when looking into his history, he has no real remarkable past medical history. But he does mention that he's had 3 concussions that were diagnosed in the past, a couple more also that were that he had without any medical follow-up. And he presented with his chief complaint, which is, my joints hurt, and lately the pain has been worsening. So when looking on the patient history and asking him a little bit more about what's been going on, he has said that it's been going on and off since he was in high school, and asking specifically about what joints hurt him. He says multiple joints are involved, specifically the lower back. He rates that a 4 out of 10 on the pain scale. His left hip, which is rated the highest severity, 8 out of 10 out of all of the other joints, as well as his right hand, specifically his third digit, and the PIP and the DIP, which is rated a 6 out of 10 for the DIP, and then the PIP was rated 2 out of 10. And one big takeaway within a clinical presentation like this is asking a little bit more about additional associated symptoms, because we're starting to sense that there's something a little bit deeper. The associated symptoms that he says he does have some dry eyes and also a rash. And then peering a little bit more into the associated symptoms, we ask him about stiffness. And when asked about morning stiffness, he says that his joints do hurt and they are stiff, but he's not sure exactly for how long. So the big takeaway from this is a patient history is very important. Even before going into any diagnostic workup, we can deduce a lot just with the patient history. And that's what I'm going to be going through with this chart. The table is actually on the right-hand side, and there's a couple of characteristics. For example, symmetry. The second one, inflammatory status. The third one is the number of joints that are involved. The fourth one is the joint involvements, and if there are small joints or medium or large joints. And going into every single characteristic specifically, the few takeaways are symmetry, asymmetric versus symmetric, inflammatory versus non-inflammatory, another criteria of the number of joints that are involved. So polyarticular would mean that there are either 4 or less joints that are involved. Polyarticular is either there's 5 joints or more that are involved. And the other one, joint involvement, that is specifically with the cervical, thoracic, or lumbar spine. And then we have the SI joint involvement as well. And then finally, we have small joints and medium or large joints, which we will go into. So going in on and referring back to the patient's history, I've put it on the right-hand side. He said that multiple joints are involved. And when looking at all of these joints, we're able to see that his pattern is asymmetric. The second criteria, which is inflammatory versus non-inflammatory, at this point from the patient history, it is not known yet. Then the number of joints that are involved, we can see that there's a total of 4 joints that are involved. So that would fall under the polyarticular category. And when we're talking about joint involvement, well, we could say that it is lumbar spine from the lower back. Left hip, we can say that it's SI joints. And then for small joints, he says that his third digit, PIP, and the DIP are affected. So that falls in the category of small joints. But in addition, his lower back or left hip pain can also be medium, classified as a medium or large joint. So a big takeaway from this article is using table 1 in our clinical practice. So going through this patient case and looking at things that are asymmetric, like this patient's symptoms. So below on this slide, actually, we see all the affected joints that are distributed asymmetrically. And we see that there are positives that are either a single positive or a double positive. And so a single positive is that it's usually present, possibly present, and then a double positive is that it's more likely. And the more likely diagnoses that have asymmetrical joints that are involved are ankylosing spondylosis and psoriatic arthritis, part of the spondyloarthritis. And then there are other ones that are possibly present, such as reactive arthritis, IBD arthritis, bacterial infectious arthritis, gout, calcium pyrophosphate deposition disease, and lastly, osteoarthritis. But a couple of other takeaways that we can get from this characteristic is that autoimmune connective diseases are symmetric, as we see with RA and systemic lupus erythematosus. And in general, the spondyloarthritis are asymmetric, as well as the crystal arthritis, such as gout and CPDD. But the infectious arthritis, they vary. So bacterial infectious arthritis, as we see in this chart, it is symmetric. And for example, we have Lyme disease caused by Borrelia burgdorferi, or viral infectious arthritis, which is asymmetric, such as HIV, hepatitis C, and parvovirus. The next category that we see in this chart is inflammatory status. And what's important to note here is that all polyarthritis are inflammatory, as denoted by this column in the row that is white. And the only one that is non-inflammatory is osteoarthritis. So what this we can classify two different arthritis from these, either inflammatory, non-inflammatory. And a couple of things that differentiate this is joint swelling. Both of these, non-inflammatory and inflammatory, will have joint swelling. However, the non-inflammatory arthritis has joint swelling that is weight-bearing, and it worsens when there is any sort of pain, any sort of movement. In contrast, inflammatory ones, they will have joint swelling, they will have erythema, but this pain is symmetric even when there is rest. And like non-inflammatory arthritis, it is asymmetric because it is going to be affecting a weight-bearing joint, like we see in osteoarthritis. And then one very important one is morning stiffness, which is why that was asked in the beginning. So prolonged morning stiffness, more than 1 hour, would be inflammatory arthritis. And non-inflammatory arthritis would have morning stiffness that is less than 1 hour. Finally, the following category is the number of joints that are involved. And the two categories under the joints that are involved are either polyarticular pattern, which is 2 or 4 joints, 2 4 joints. So some spondyloarthropathies are polyarticular, as we see the ankylosing spondylitis, as well as psoriatic arthritis. And then some infectious arthritis are polyarticular, such as reactive arthritis, and IBD arthritis, and bacterial arthritis. And for the polyarticular pattern, that's for joints that are greater or equal than 5 in quantity. So that would be the autoimmune connective tissue diseases. All of those are polyarticular, such as rheumatoid arthritis, systemic lupus erythematosus, and what we see also in this chart is, in this specific row, is that it's not necessarily a hard rule, as evident by only one positive sign. And so we don't see any double positives here, which means that it's more likely to happen. So it's not a hard rule. Then we have joint involvement. So this table was now collapsed just to show the joint involvement, but it's still following the previous one, which was the number of joints that were involved. Going into joint involvement, we have either spine involvement or SI joints. Spine involvement would be either cervical spine, when the patient's complaining of mid-back pain or thoracic spine, or lower back pain, which is lumbar spine. And the polyarticular arthritis that fall under this category are the spondyloarthritis, rheumatoid arthritis as well, reactive arthritis, and then inflammatory bowel disease arthritis, as well as osteoarthritis and bacterial. And one thing that is also important is that we do see a double positive for and this only for one diagnosis within the spondyloarthritis. And the SI joints, well, we can see from this table that they go hand in hand with uh, any sort of polyarticular arthritis that would also have spine involvement. So in every single category, every single column, we see that there is a positive or a double positive that also corresponds with SI joints. The only one that we don't see is under bacterial, and that would only be spinal involvement and not necessarily any SI joint involvement. So one other category of involvement with joint involvement is small joints or the medium to large joints. And the small joints, they encompass the wrists, the carpal metacarpals, the metacarpal phalangeals, the proximal interphalangeals, and the distal interphalangeals, as well as the ankle and the metatarsal phalangeals. From this chart, we see that those that have that have smaller joint involvement is rheumatoid arthritis, lupus, and viral arthritis. Whereas the majority of the ones that have medium to large joint involvement are essentially all of them, except for viral and gout, which is left without any sort of medium and large joint involvement. When we're going back to this patient's case, he did say that his symptoms of pain are both in the hip and in the lower back. So this can also be classified either SI joint involvement or as a hip involvement. And for the SI joints, the rheumatoid arthritis, as well as ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease arthritis, and osteoarthritis all have sacroiliac joint involvement, where the hip involvement essentially also encompass the same polyarticular arthritis diagnoses. In addition to that, it also encompasses PMR, the vasculitis like polymyalgia rheumatica and polyarteritis nodosa, as well as bacterial arthritis and calcium pyrophosphate deposition disease. So in addition to this, there's a following row that talks about extra-articular symptoms. And these are very important because they do help narrow down the diagnostic options. And the reason why is because it'll tell us that there is something further going on that is pointing to a systemic inflammatory arthropathy. And so these extra-articular symptoms are rashes, ulcerations in the oral or genital mucosa, if your patient has Raynaud phenomenon, or serositis with pleurisy and pericarditis, Zika symptoms of dry eyes and dry mouth, or inflammation of the eye or bowel, as well as neurologic symptoms. And the most common ones that we'd see is numbness or tingling sensation. And lastly, if a patient is having ischemic symptoms, including stroke, all of these extra-articular symptoms can help us narrow down the diagnostic options to a systemic inflammatory arthropathy. And so the following row has systemic features. Going back to the patient and what his symptoms were, associated symptoms were dry eyes and a rash. So dry eyes can be classified as uveitis as well. And the systemic features that have uveitis, the diagnoses that has uveitis are rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. And he also said he had a rash. So diseases that have this are systemic lupus erythematosus, vasculitis, psoriatic arthritis, and viral arthritis. So going back to this table and either using a highlighter or as I've shown over here, we were able to basically highlight everything. He said he had asymmetric joint involvement, polyarticular joint involvement, SI joint involvement, as well as lumbar joint involvement. And then as well, he had PIP and DIP involvement and systemic, as well as hip involvement and systemic features as well, which have all been highlighted. But before we go into how the table can help us narrow down this diagnosis before any sort of workup, we have to first look out for red flags because these have to be not only recognized properly, but because they are they present acutely, we have to treat them even before going down these other diagnoses pathways. So the first one would be septic arthritis, and that typically is involving a large joint such as the knee, but it can affect several other joints. And it also, the patient would be complaining of either malaise, weight loss, if he has fevers or swollen or warm joints. Another red flag condition that we have to look out for are neuropathies, radiculopathies, myelopathies, and or other neuromuscular diseases. And the ways that this would manifest is if the patient is either having numbness or burning pain, if it's unlikely to worsen with any joint movement, it worsens at night, or if there's any weakness. And one other very important red flag that we should look out for is compartment syndrome. And this is when joint pain exceeds what we would expect based on any other physical exam findings. So all of these coupled together, we have to look for weight loss, night sweats, fever, and fatigue, all red flags, as well as sepsis or infection. And one other note that we have to make from this paper is that there are some comorbid conditions that can worsen pain. So one of the most common ones is diabetes, and especially if a patient has complications of neuropathy. Depression can also worsen polyarticular pain, and polypharmacy, use of many medications can cause arthritis. For example, drug-induced lupus arthritis. The most common ones are hydralazine for blood pressure, isoniazid for tuberculosis, phenytoin for seizures, sulfalazine for IBD arthritis, and chlorpromazine for psychiatric disorders. Other comorbid conditions that can worsen the pain are Lyme disease if you have an endemic area with exposure to ticks such as the Northeast, and hepatitis C, parvovirus, or HIV, which all can lead to viral arthritis. So going back to this table again and where we highlighted, we're able to clearly see which disease has the most symptoms highlighted. And by counting every single one of these symptoms, we're able to see that number 8, which is psoriatic arthritis, is the disease that has the most symptoms that correlate with this patient. So the answer ended up being that he had psoriatic arthritis, but it was actually compounded by a new comorbid condition, which was Lyme disease. So he had a recent episode of pain that led him to pursue medical care. And this comorbid condition amplified the psoriatic arthritis that wasn't diagnosed before. So he does have underlying psoriasis and this recent Lyme disease infection. And other things that we can take from this chart is that not only is psoriatic arthritis one of the diseases that has the most symptoms that are correlating with the disease, but there are other ones such as reactive arthritis, ankylosing spondylitis, and then IBD or bacterial. So this is the table, again, that we can use as a reference in the clinic. But before even going to the following step, which is ordering blood work, physical exam can help us narrow down a really big part of this table, which is inflammatory status or not. So inflammatory arthritis does have erythema, and it has warmth. Whereas non-inflammatory arthritis, and the only disease that had that was non-inflammatory in our table was osteoarthritis. So non-inflammatory arthritis, like OA, would not have erythema and warmth, but it would have swelling and tenderness. Whereas inflammatory arthritis has erythema, warmth, and also swelling and tenderness. There are some physical exam findings that we should think about other, that should help us, that should lead us to thinking about other conditions that mimic inflammatory arthritis. And so, for example, if we're doing testing of active or resisted range of motion and there's pain, we should be thinking of muscles, tendons, or bursa. We feel crepitus, and it should be without warmth or erythema. Then we're thinking about osteoarthritis. If we notice that there is normal passive range of motion, but then the active range of motion is reduced because of pain, well, then we're thinking of a tendonitis, a bursitis, or a muscle injury. And finally, if both active and passive range of motion is reduced, we're thinking of joint abnormalities, synovitis, and soft tissue contractures. And one of the key takeaways for the workup, now that we've gotten to this final step of checking for laboratory markers, is the best practice models recommendations from the Choosing Wisely campaign. And one of the most common things that we all think about is ANA, and drawing an ANA for whenever we think of an systemic arthritis. However, what we should know is that only 2% of lupus patients do not have ANA. So if we do draw an ANA and it is negative, it is unlikely that that patient has lupus. And also, in addition to that, even though they might have a positive ANA, it doesn't always mean that it's lupus, since ANA is associated with many other autoimmune diseases. And then another takeaway that we can take for gout, for example, there is MD Calc, acute gout diagnosis rule, and it takes into account the sex, if the patient is a male, if they had a previous reported arthritis attack, if the onset was within 1 day, they had joint redness, if their first metatarsophalangeal joint was involved, or hypertension, or serum uric acid that is elevated. The maximum points that we can get is 13 points, which is an 82% prevalence of gout. So even before doing any sort of extensive laboratory workup, then we can use MD Calc for this. So one final takeaway within the workup diagnoses is that nearly 50% of patients with polyarticular pain will have unclassifiable conditions that are past this table. So these patients may not need medication for the time being, because they may go into remission within a year, but that still doesn't mean that they wouldn't benefit from medications for symptomatic relief in the meantime. So 5 take-home points from this article is that this table is a very useful diagnostic tool when we want to diagnose polyarticular arthritis in the sports medicine clinic. And a good practice to have with polyarticular arthritis symptoms is asking for associated symptoms, especially when patients are complaining of multiple joint pains. But we have to watch out for red flag signs and symptoms that point to conditions like septic arthritis, neuropathies, or compartment syndrome. And in the following, when we're seeing erythema and warmth in physical exams, we should be thinking of inflammatory arthritis. But without that, we should be thinking of non-inflammatory arthritis, which is osteoarthritis. And finally, looking out for comorbid conditions is very important, because it can worsen polyarticular arthritis. These are the sources. Thank you.
That was great. Thank you for your presentation. I liked how you kind of went through the article very thoroughly, and it gives the article itself and just your presentation, it gives a good framework for approaching any patient. Because I feel like I'm pretty early on in my career and I'm already seeing patients that are like this. So this is a good refresher for me as well. Dr. Pujalte, do you have any additional comments about the article or topic that you'd like to share?
Yeah, I was really amazed as how Dr. Morales tackled this, because this is kind of how we imagined the table would be used, especially that that slide. Dr. Morales, I wonder if you can show the slide where you had numbers underneath. You know, I had trained in a place where we wrote this article because where I trained, there was not a lot of Lyme disease and all that. But when I moved Northwest, as you know, Dr. Patel, then we started seeing these strange presentations of like multiple joints and all that. And turned out they were Lyme. And I started to have an interest in such conditions. And I even wrote 2 articles on tick-borne illnesses because I really was trying to understand how these things or conditions can present. And how Dr. Morales did it here is precisely how we would imagine people would use this, where they would look at the left side, symmetry and all that, and then they would look at the conditions that had those. We didn't think of highlighting, so that was a good thing that Dr. Morales had done. We were gonna just check each one and then look how many checks you had for each column, but highlighting truly emphasizes just by looking at it, which one you think are the most possible conditions occurring in the patient. So very good job, Dr. Morales, using this table. Thank you, Dr. Patel.
Of course. And then I'll open it up to some questions if you guys want to type anything in, anything that's lingering from this. But I have a few questions to ask. At what point in your when you're evaluating a patient, do you refer over to a rheumatologist or subspecialty and get a consultation?
Yeah, so I mean, when you're thinking about rheumatology or any subspecialty, really, for example, dermatology, it would be if you're having unclassified arthritis, which is, 50% of the patients are not going to fall in this category. And it's not only unclassifiable, but it's persistent, as we saw in this article. About 50% of patients are actually going to be going into remission. And if it's going on for way past that, without any symptomatic relief, then we would do a subspecialty referral.
Okay, excellent. That makes sense. And then another question we have come in is, how do basic inflammatory markers like ESR, CRP, how do those factor in and help distinguish between inflammatory versus non-inflammatory arthritis?
Yeah, so the thing is that with ESR, elevated sedimentation rate, and CRP, the ESR is more chronic and the CRP is more acute. But either ways, both of them are going to be elevated with any inflammatory arthritis. So say RA, for example. But the thing is that it is non-specific. And so it can arise in any other infection. So if you have a malignancy, if you have an infection, any other systemic conditions that would have an elevated level. So it doesn't really add anything.
Great. And then the last question that we had come in, what diagnostic testing would we order to confirm this patient's psoriasis and Lyme disease?
Well, actually, the thing with psoriasis psoriasis and as we saw in this case, is that there's no specific blood work for psoriasis and psoriatic arthritis. And that's why history and physical exam findings are important, because they play a huge role in the diagnoses. And that's why I'm pointing at this table before doing any blood work. But if it's still unclear, of course, the dermatologist can go to, the patient can go to a dermatologist and get a skin biopsy. And in those cases, they would do a PAS stain. And then that would see if it's a fungal infection, or if it's cleared from that, then it's most likely psoriasis. There's not really a lot of things that we can do in like ordering blood work. But for Lyme disease, actually, what we could do is just check to see if there's any serological testing of antibodies for Lyme disease. So IgG for the chronic phase, or IgM if we're suspecting that there is an acute phase. And then also, in addition to that, we can check for joint and blood culture. So there's a lot of things that we can do in that case.
Great. Yeah, I mean, I think you just have to keep these diagnoses on your differential to even like think to order this stuff. But excellent presentation and great article, of course. Great author. Glad you have him with us tonight. So we're just going to move on. I want to keep us on schedule. So we're going to move on to our second presentation. Pleased to introduce our second presenter, Dr. Tae Kim, and his club mentor, Dr. Moira Davenport. So his full name is actually Taesung Kim, but everyone calls him Tae. Dr. Kim is currently a PGY3 resident at Stony Brook University PM&R residency program. He's very passionate about sports medicine. In particular, Dr. Kim has a strong interest in combat sports. Fun fact, he's actually a black belt in Brazilian Jiu-Jitsu and served as a cornerman for a fighter in the UFC. His presentation is on the article Use of Ergogenic Aids by Athletes. And I'd also like to thank Dr. Moira Davenport for serving as club mentor. Dr. Davenport is an emergency medicine and sports medicine trained physician. She is the current Associate Residency Director and Medical Education Fellowship Director at Allegheny General Hospital in Pittsburgh, Pennsylvania. Most of her sports medicine knowledge has been gleaned by rehabbing her numerous sports-related injuries from high school, college, and her adult life. She still runs and does CrossFit, but has added Lego building with her son to reduce the likelihood of injuries. So without further ado, I'll turn it over to Dr. Kim for his presentation.
Awesome. Thank you so much, Dr. Patel. Okay. All right. Hi, everyone. So the name of the article that I'm going to be covering today is The Use of Ergogenic Aids by Athletes. It's by Dr. Mark Silver. And just one thing to note before I continue is that this article was published in 2001. So, as you can imagine, there's some, updated information and whatnot. But generally, this paper is still, great for foundational knowledge. And the point of this article, I wanted to kind of, without getting into too much details about particular aids, one as more of a broad overview and essentially how it essentially applies to us as roles as a sports medicine physician. Okay, so ergogenic aid is defined as any means of enhancing energy utilizations, including energy production, control, and efficiency. Okay, so in a 1997 poll by Sports Illustrated, they asked Olympic athletes 2 questions. First one was, would you take banned performance-enhancing drugs, and if you're guaranteed to win and not get caught? So 98% said yes. And the second question, they said, would you take the same substance if it would enhance your ability to win every competition for the next 5 years, but then it would result in your death? And even more surprisingly, more than 50% said yes. So this kind of highlights the mentality of a really very competitive, professional athletes. So us as physicians, we have to kind of understand their psyche, their point of view, so that we can better help them in as far as guiding their medical treatments, and also helping educate them on these types of ergogenic aids and essentially the harm that it could potentially do to them. So ergogenic aids. So the significance is that athletes use these aids to gain advantages in performance, as well as improves physique, depending on what they're trying to get. So as far as the prevalence, yeah, I wasn't so sure if some of the the facts about this, how true it was, but they said that about an estimated 1 to 3 million people use anabolic steroids in the U.S. So I think it's in the context of back in 2001. And as far as the impact, there's a widespread use poses physical harm and undermines fair competition, especially within the professional athlete setting. And there's multiple types of ergogenic aids. There's mechanical, psychological, physiologic, pharmacological, and nutritional. So, but for the purposes of this paper, we're going to focus on the physiologic, the pharmacological, as well as the nutritional. So looking from a historical perspective, so the first Olympic Games took place in Greece in around 1776 BC. And even back then, ancient texts depict that athletes used hallucinogenic mushrooms and sesame seeds to enhance performance. And then in 1889, Charles Edward Brown-Séquard, a French physiologist, claimed to have reversed his own age process by self-injecting testicular extracts, or what we today have come to know as testosterone. So in the modern era, testosterone was first synthesized in 1935, and anabolic steroid use has been ongoing since 1940s. So in response to these ergogenic aids that have kind of come up and people have kind of realized that it's becoming a problem, is the Olympic banned amphetamines and steroids first in the 1960s, and then drug testing started in 1968. So in order to combat a lot of these life-threatening use of drug by athletes and use contrary to the ethics and ideals of fair competition, in 1963, the Council of Europe they first came up with a medical commission to enforce prohibition of performance-enhancing drugs. Oh, I'm sorry, that was International Olympic Committee, IOC, in 1967. And then in 1973, in the United States, following congressional hearing, major athletic organizations such as the NCAA, NFL, USA Track and Field, and the United States Olympic Committee started implementing drug programs. And then since then as well, the organizations such as the World Anti-Doping Agency, and then in the United States, the United States Anti-Doping Agency have kind of taken that role to help kind of regulate a lot of the professional sports domains, as well as some of the more popular competitive sports as well. So the role of the physician, so us as sports medicine physician, it's our duty to kind of educate ourselves and be knowledgeable on counseling, on the risks and the legality of ergogenic aids to our patients. And then also we have to know how to treat, right? So we have to support the athletes recovering from adverse effects, as well as monitor them for long-term health effects. And then what I've kind of mentioned before is our role in educating. I think our role is not just clinicians, but we also need to be teachers and educate and promote awareness about ethical practices and natural performance enhancement versus using unfair advantages, which could again have long-term health effects. So the paper they kind of dove into a bunch of different ergogenic aids, but for the sake of time, I chose a few to kind of highlight, and yeah, so we'll go from there. So the first one I like to kind of highlight is anabolic steroids. This is probably the most popular one, and as I mentioned before, it's been in use since the 1940s, and the mechanism of action is a anabolic androgenic steroids. They're synthetic derivatives of testosterone that induce protein synthesis in muscles by stimulating the release of endogenous growth hormone, and they reverse the catabolic effects of cortisol use. So clinically, they're actually used for hypogonadism or impotence, and to reverse the wasting effects of conditions such as burns and chronic debilitating illnesses. However, for the athletes that take these steroids, they're looking to increase muscle mass, strength, enhance recovery, and improve their athletic performance. And just one thing to note, the injectable forms are less hepatotoxic than the oral preparations. However, they are detectable in a drug testing for a longer period of time. So one interesting thing that I kind of that the article kind of discusses, and something that I personally didn't know about, is that the incidence of serious side effect is actually relatively low, and a lot of the adverse effects is actually it's based on its effects in therapeutic use. So it's kind of interesting to see that that it's not as far as what the literature tells us, it's not as detrimental, in other words, like have so much statistical value to tell us that like a big chunk of people that take these things are going to have a lot of long-term effects, but that doesn't mean that it's safe in any ways. But multiple organs and systems can potentially be impacted. There are documented reports where it can induce tendon rupture, osteonecrosis of the hip, psychosis, and even in rare cases, suicidal behavior. And then in use in women, it could have masculizing effect, and then in children, it could limit growth. And then in males, it can cause virilization or cause female characteristics. But however, all this depends on the dosage, duration of treatment, and the particular steroid type used, because there's a bunch of different derivatives, and each derivative or the way it's synthesized, it causes like different risks. However, there are few cases of death due to hepatocarcinoma, myocardial infarction, and stroke with prolonged steroid use. So there are different administration techniques of taking anabolic steroids that some of these, I guess, bodybuilders particularly have kind of employed. And one of them is stacking. It's using a combination of anabolic steroid preparations to get the highest effect possible. And then cycles, taking them in 6 to 12 week cycles, And lastly, pyramiding, meaning athletes gradually increase the dose throughout the cycle. And all these three methods, they're intended to maximize benefits and minimize side effects. However, no scientific proof supports that it does work. However, it's a case of a bro science, I would like to say. Concomitant drug use. So a lot of times athletes use other drugs alongside anabolic steroids for different reasons. Number one, they'll take diuretics to reduce fluid retention. They'll use anti-estrogens to combat estrogenic effects. And sometimes they'll take ACG to maintain natural testosterone levels, especially after they get off their initial cycle, as well as anti-acne medication to address skin-related side effects. Okay, so now we're going to go into other ergogenic aids. Number one, growth hormone. So it's produced naturally by the pituitary gland, and the mechanism of action is that it accelerates amino acid incorporation into proteins, and it stimulates lipid utilization, sparing muscle glycogen. And athletes expect to increase muscle mass and strength, and the adverse effects include gigantism-like features in children, acromegaly in adults, and risks include heart disease, glucose intolerance, and osteoporosis. And if you guys know Andre the Giant, he's up there in the top right corner. He had he was born with gigantism, hence he wasn't taking those growth hormones. But that's what we expect to see if someone had that type of endocrine pathology. And then here's Sylvester Stallone. So he admitted to using growth hormones, especially back in his days when he was casted as Rambo in his in those movies. I'm sure he uses some of that still today because he looks pretty good for the age he is. Okay, and then androstenedione, hard for me to pronounce, but so the mechanism of action of this particular drug is that it's a testosterone precursor to promote muscle mass, and athletes expect with its use to improve recovery and strength. However, most studies show unlikely to prove any anabolic benefit, which was something that was interesting when I was looking up some papers regarding it. And then the adverse effects is that it reduces HDL cholesterol and increases estrogen levels, and risk factors again include cardiovascular disease, breast cancer, and it can induce gynecomastia. So there was a famous baseball player by the name of Mark McGwire who actually admitted to taking this a drug among other things. But it's funny because some of the papers that I'm seeing now, the consensus statement is that it's unlikely to provide any anabolic benefit. So everyone was kind of giving him a lot of shade. But at the end of the day, it looks like for this drug he took, at least it didn't really help him. So maybe that there is a lot of psychological component to his having these drugs to kind of aid performance and whatnot. And then recombinant human erythropoietin, or also known as EPO. I'm sure we've all heard about this. It's a natural hormone produced by the kidneys, and the mechanism of action regulates erythropoiesis, or the production of blood cells. And by increasing, red blood cells, it increases oxygen carrying capacity. Athletes' expectation improved endurance and time to exhaustion. Especially this is imperative, especially in long distance athletes such as the Tour de France with Lance Armstrong. Yep. And adverse effects: blood hyperviscosity, ischemic events, hypertension, and hyperkalemia, and it's banned by the International Olympic Committee since 1990. And then creatine as a supplement. I'm not sure if any of you guys work out, go to the gym. A lot of people actually use creatine. And the mechanism of action with creatine is that it enhances ATP production during anaerobic activity, improves muscle buffering capacity. At the expectations that it's expected to increase strength and power for short duration, high intensity exercises. Adverse effects is weight gain, muscle cramping, gastrointestinal distress, and potential kidney issues if not drinking enough water while taking the supplement. Dosing, as long as it's about 50, is kept within 15 to 30 grams a day, and maintenance with 2 to 5 grams per day. It's actually shown to be a relatively safe supplement to use. And lastly, I want to also talk about caffeine. So caffeine mechanism of action. I think we all drink drink some have some sort of caffeine intake, especially for, you know, if you're on call and whatnot. But mechanism of action stimulates the sympathetic nervous system, enhances intracellular utilization of free fatty acids and athlete expectations, improves endurance during prolonged or intense exercises, or when we're doing extra admissions when we're on call. And then adverse effects include anxiety, jitters, insomnia, cardiac arrhythmias at higher doses. And one thing that I remember when I was a college athlete for a little while, the NCAA limits the amount of caffeine in an athlete's system, and the limit was 15 micrograms per milliliter in the urine, and this is equivalent to about 6 to 8 cups of coffee drank about 2 to 3 hours before like an athletic event. And I just wanted to briefly just talk about I just want to emphasize that there's new ergogenic aids that's popping up. So again, I just wanted to highlight that us as sports medicine physicians, that we would educate ourselves so that we can educate, you know, our patients, because a lot of times there's new things popping up. So we always have to be staying on top of learning about all these different types of supplements, drugs, and whatnot to help our patients. So the particular I guess supplement or the drug that I wanted to mention was BPC 157, or pentadicapeptide. Yeah, so it's a body protective protein 157. It's a synthetic peptide derived from a naturally occurring protein in the stomach. It's known for its regenerative and protective properties in animal models. And the mechanism of action is that it enhances angiogenesis, which means formulation of new blood vessels, and promotes collagen production for tissue repair, as well as reduces inflammation and oxidative stress. In athletes, they use it to accelerate healing of muscle, tendon, and ligament injuries. They enhance recovery from physical exertion and injury, and they potentially protect against gastrointestinal issues due to related stress. So the one thing, the reason why I found out about this particular drug is that in like the jiu-jitsu world, it's a small community where I'm from. So that, you know, all the guys are talking about it now, and they're always asking me like, do you know anything about this? Do you know anything about this? So I thought it'd be worth it to kind of look it up, and I thought it was pretty interesting how new things like this pop up. But now, as far as adverse effects, you know, because the relative new drug, there's really limited long-term safety data, and there's unclear dosing standards, which may result in misuse or overuse, as you guys can imagine. And then as far as legal and regulatory status of this particular drug, it's not approved for human use by any of the major health organizations, including FDA. So it's an off-label use, and it's usually sourced through unregulated markets. And also, it's based on WADA. It's explicitly not a particularly banned substance, but it falls under the non-approved substances. So in conclusion, ergogenic aids are a double-edged sword. While enhancing performance, they pose significant ethical and health challenges. Physicians play a critical role in education, prevention, and management of complications associated with their use. And it's important for continued research and evidence-based approach to regulations are necessary to uphold the integrity and safety of the sports. In other words, instead of just saying telling these athletes you shouldn't be on these, which we should also kind of let them know about the health risk. We should also be realistic and kind of give them more of a objective view, the science behind it, to really help them in their in their pursuit of achieving their athletic goals, but at the same time making sure that they're doing it safe, and especially so that they can then have long, healthy lives. So special thank you to Dr. Davenport, and thank you everyone for your time. And this is my We're Excited.
Perfect. I think that was a great presentation. Nicely outlined the different aids that there are, and especially in my clinic, I'm getting a lot of questions from patients that are trying to get that extra edge, especially when they're recovering, trying to get back to a certain level, the aging population as well. And I think we're going to see a lot of that just because there's been such an emphasis on health and wellness, like people looking for that extra edge when it comes to rehabilitation, when it comes to just performing in their sport, whether, you know, it doesn't have to be like Olympic level, professional level, just like, you know, from weekend warrior to competing in marathon. So it is good to become well versed on these things. So when patients ask you, you don't just have to say, oh, I don't know, or it's bad for you. You can kind of give some evidence behind it and give them some resources if they're going to kind of continue to pursue to do this. So some questions I had from the audience. The first one, what evidence did you read, if any, about steroids and their use? And if they think like what is the evidence behind the steroids that led them to being banned? Or are they banned more for their more established adverse effects?
I think that's kind of a little bit of a complex question, but I think the question is number one, anabolic steroids, if you know, if used improperly, obviously it will have all those negative impacts that we've kind of discussed before. But with that being said, a lot of the bad side effects that we didn't mention was, again, from clinical use of it, which is more so in a controlled setting. So as far as to show us like the concrete like data of like, you know, how much of adverse effects it would have if, let's say, that, you know, someone did use it or like in outside of a clinical setting, it might be worse adverse effects, you know, but as far as the actual data, it's kind of difficult to say exactly, but it can cause significant, you know, permanent long-term adverse effects, like we mentioned before. And in some few cases, you know, there are reported deaths of it. And I'm sure you guys heard, like, for example, Arnold Schwarzenegger, like, you know, he has like, I think he has really complicated heart issues, and I'm sure it has to do with his, you know, steroid use. And I think there was a famous bodybuilder that just died from a heart attack too. So obviously, you know, it does show that it does have adverse effects. But, you know, just to kind of mention before that, there was that one thing that I did say is that as far as the really detrimental adverse effects, there's not a lot of documentation of that, which I thought was particularly surprising.
Awesome. And then one more question. Have you read anything just kind of when you're preparing this about genetic manipulation? And if so, like, have you heard of athletes starting to use them or anything like that?
Genetic manipulation? No, unfortunately, no, I actually did not even come across anything like that. So that's actually pretty interesting.
Sure. Yeah. And that's like just kind of a new space that's coming about. And then I just wanted to give the floor to Dr. Davenport if you had anything to add about the topic or the paper or anything.
Sure. Yeah, no, first of all, I want to thank Dr. Kim for his presentation. I think it was really thorough. He did a great job reviewing the agents, and I think the agents covered in this paper are things that we all are going to face in our sports medicine career, so it's really helpful to review them and review some of the mechanisms of action that way. I think one thing that Dr. Kim alluded to is that in different sports, people tend to use more supplements and more performance-enhancing agents than in other sports, so it's really good to familiarize yourself with agents that are common. There are some great resources out there. The NSF for sports safety is a great resource. It deals primarily with supplements, not so much with the anabolic agents. And then make sure you check out the US Anti-Doping and World Anti-Doping Administration websites. Global DRO is a great resource. You have to enter your country, enter the sport, and then you can enter the substance that you're looking at, and it will tell you if it's approved in competition, out of competition, what kind of testing you need, if you need a therapeutic use exemption. So just really be aware of the resources and be aware of the trends that are in whatever sport you're covering.
Yeah, and I think that's super important, especially if you're working in college athletics or professional sports. That could have big ramifications if you're the one giving the clearance, and if they're the ones asking you if they're okay to take certain supplements or enhancing drugs.
Absolutely.
Great. Well, I just want to thank our two presenters, Dr. Morales and Dr. Kim, for their outstanding presentations. It was amazing to have Dr. Pujalte share his insights on his article that Dr. Morales presented as the primary author of the article and for serving as a club mentor for Dr. Morales. Also, we want to thank Dr. Moira Davenport for serving as a club mentor for Dr. Kim. And I'd like to thank everyone who attended tonight's AMSSM Journal Club. It's also my pleasure to serve as a club advisor moderating tonight's Journal Club meeting. I'm pleased to announce our next AMSSM Journal Club will be held on Tuesday, January 7th from 8 to 9 Eastern. So I hope you'll make plans to join us, and that will conclude tonight's meeting. So thanks for joining us.
Bye, everyone.
Bye. Thank you.
Thank you, everyone. Thank you, Dr. Davenport.